Hi, I'm Dr. Pranav. My topic of discussion is lung ultrasound in ARDS, a non-radiation alternative to CT prospective observational study. Acute respiratory distress syndrome is a life-threatening clinical condition characterized by acute onset of hypoxemia, bilateral pulmonary infiltrates, and decreased lung compliance occurring in absence of cardiogenic pulmonary edema. It represents a common final pathway of lung injury resulting from diverse direct and indirect insults such as pneumonia, sepsis, aspiration, trauma, pancreatitis. Chest radiography is widely used for diagnosis of ARDS, but CT image helps in differentiating ARDS from other causes of acute respiratory failure and help guide the ventilator strategies such as positive and predictive pressure optimization and prone positioning. In recent years, lung ultrasound has emerged a valuable bedside imaging modality for assessment of various pulmonary conditions in critically ill patient, as it is free from ionizing radiation, portability, repeatability, and can be performed at the point of care without interrupting ongoing life support measures. The aim of study is to evaluate the role of lung ultrasound as a non-radiation imaging modality in assessment of lung involvement and severity in patients with acute respiratory distress syndrome, and objective being to correlate the lung ultrasound finding and lung ultrasound score with severity of ARDS in adult patient. The study design being prospective observational study, which is conducted between the Department of Radiodiagnosis and the Department of Medicine, and study population being adult patient admitted to intensive care unit and diagnosed with ARDS as per Berlin definition. Sample size was calculated and it came up to be 54 and it was rounded off to 50. The inclusion criteria were age group more than or equal to 18 years, diagnosed with ARDS according to Berlin definition, admitted to intensive care unit, and hemodynamically stable at the time of lung ultrasound examination. The exclusion criteria being pre-existing chronic interstitial lung disease, significant chest wall deformity, or subcutaneous emphysema, which would affect the ultrasound assessment, history of pneumonectomy, and refusal of consent by patient. Ultrasound lung was performed at bedside using portable ultrasound machine with low frequency curvilinear probe, and each patient underwent a standardized 12 zones ultrasound protocol with both hemithorax divided into anterior, lateral, and posterior region. Ultrasound findings were A line, focal or diffuse B line, confluent B line, pleural line irregularity, subpleural consolidation, and large consolidation of dynamic ear bronchogram. Assessment of ERDS severity was categorized into mild, moderate, and severe based on PaO2 by FiO2 ratio as per Berlin definition. Data collection and statistical analysis was done, and this picture depicts both hemithorax, which are divided into different zone for the approach of study. These are few pictures from the study. The first picture depicts chest X-ray showing complete opacification of left lung, and second picture is lung ultrasound demonstrating pneumonia with irregular hypoechoic consolidation air bronchogram, multiple hyperechoic B line, which is depicted by long arrow, and hypoechoic pleural thin line, which is by short arrow. The results were tabulated in this fashion. The first table showing demographic and clinical characteristics of study population, which consist of middle-aged patient, mostly male predominance. Most of this patient had moderate to severe hypoxemia reflected by low mean PaO2 by FiO2 ratio, and majority required invasive mechanical ventilation indicating significant decreased severity. The second table depicts ARDS severity, which was relatively even across mild, moderate, and severe categories, allowing meaningful comparison of lung ultrasound finding across different severity grades. The third table depicts lung ultrasound finding, which were diffuse B line, pleural line abnormality, which are the most common findings on lung ultrasound, reflecting widespread interstitial and alveolar involvement. Posterior lung zone were predominantly affected and consistent with dependent lung pathologies seen in ARDS. The fourth table shows lung ultrasound score and ARDS severity, which shows the mean lung ultrasound score showed a progressive increase with worsening ARDS severity. And fifth table shows the correlation between lung ultrasound and PaO2 FiO2 ratio, which indicates that higher ultrasound score were associated with worse oxygenation. This sixth table shows comparison between CT and lung ultrasound, and this depicts lung ultrasound demonstrate higher concordance with CT finding, particularly with respect to consolidation, in lung and posterior lung involvement. The discussion was in the study of 50 ARDS patients, lung ultrasound consistently identified hallmark features of ARDS, including diffuse B line, pleural line abnormalities, subpleural consolidation, and comparison CT finding performed in a settle of clinically stable patient revealed high concordance between lung ultrasound and CT in detecting consolidation and posterior lung involvement. While CT remains superior in identifying the subtle ground glass opacity, lung ultrasound demonstrate excessive and excellent sensitivity for clinical significant lung pathologies. The conclusion was this study demonstrates that lung ultrasound is an effective and non-radiation imaging modality in evaluating of lung involvement in patients with acute respiratory distress syndrome. Lung ultrasound finding, particularly diffuse B-line pleural abnormality consolidation, were consistently observed and showed a strong correlation with ARDS severity and oxygen impairment. The lung ultrasound score increased progressively with worsening disease and exhibit a significant inverse relationship with PaO2 by FiO2 ratio. High concordance between lung ultrasound and CT finding further supports a diagnostic reliability. Given its bedside availability and repeatability and absence of radiation exposure and flexibility in critically ill patient, lung ultrasound can serve as practical alternative to CT for both diagnosis as well as monitoring of ARDS. These are the reference articles which are taken. Thank you so much. Happy Christmas. Happy New Year.
Okay.
Okay.
Technically,
हैप्पी क्रिसमस हैप्पी क्रिसमस
ये किसका था अभी?
इसका
हो गया ना?
नो तेरे को देख भाई, तेरे को कुछ और
भेज दे।
नौटंकी करना है तो तेरे सोचने बहुत रहता है।
अब वो दूसरा बना दे, पढ़ते खत्म करो।
बना दो।
तेरे को मैं नहलाता हूँ भाई कॉम्प्लीमेंट पे।
छोड़ अभी गुस्सा में।
भाई मैंने क्या किया भाई? सबका मेरे पे क्यों निकाल रहा है भाई तू? मेरे व्हाट डिड आई डू?
अभी क्यों?
अरे भाई बाकी सब तो अच्छे से बात कर रहे, बोल रहे तो मेरे ना पूछ रहे।